Good afternoon and welcome to the Regional Geriatric Rounds. My name is Laura Wilding and I'm the Director of the Regional Geriatric Program of Eastern Ontario, and I'll be the moderator for today's session. Before we begin today's presentation, we'd like to take a moment to share a territorial land acknowledgement. The RGPEO offices are hosted by the Ottawa Hospital and are located on the traditional unceded territory of the Algonquin Anishinaabe Nation. The Algonquin people have lived here since time immemorial. We are grateful to have the opportunity to be present in this territory. We welcome Dr. Kenneth Rockwood, who will be presenting on frailty and dementia. Dr. Ken Rockwood attended medical school at Memorial University in St. John's, Newfoundland, completed training in internal medicine at the University of Alberta, and his subspecialty in geriatric medicine from Dalhousie University. He's currently a professor of geriatric medicine and neurology and the Catherine Allen Weldon Professor of Alzheimer Research at Dalhousie University in Halifax, Nova Scotia, and a member of the senior leadership team at Nova Scotia Health. He is the inaugural leader of the Frailty and Elder Care Network and has key roles on numerous studies in Canada and elsewhere. He is recognized as a leading international expert on frailty. Welcome, Dr. Rockwood. We're really happy to have you here with us and honored to have you share your expertise with us today.
Thank you. I guess the question is, I can share expertise, but can I share the screen? Okay. I have a land acknowledgement as well. So I'm speaking from Halifax in Nova Scotia, Mi'kma'ki, the ancestral unceded territory of the Mi'kmaq people. So I want to address this issue of frailty and dementia and whether they're linked. And thank you for the opportunity to talk about this. I'll start with some disclosures, which consist in a bunch of frailty tools that we've developed over the years. We've put all this in the public domain. And we've asserted copyright for it, though, to prevent other people from charging you. So you can go to the geriatric medicine website at DAL and download the stuff for free, but we do ask you to sign something saying that you won't turn around and commercialize them. There's a wee company called Ardea Outcomes, which exists still despite the pandemic, doesn't do any frailty work. And I edit Brockler's textbook of geriatric medicine and gerontology, which says a lot about frailty. So I guess we're now at the intersection between disclosure and advertising, but there it is. So I have three objectives. One is to discuss frailty and its relationship with aging. I'm going to focus on the understanding of frailty that I know best. The second one is I'm going to make the case that we should view late life dementia as a multiply determined disorder in which frailty actually has a crucial role. It's not a bystander. It's key to who expresses the neuropathology. And then spend a few minutes considering what this means for how we treat patients, do trials, think about prevention, and aim to treat dementia itself. So let's start with this. The number of people with dementia is rising. The absolute numbers of people is going up. But the dementia incidence is falling, right? So we have a smaller number, a smaller fraction of a bigger number remains a big number and bigger than we've had. And although the incidence of dementia is falling, there's reasonable data to suggest that the incidence of cognitive impairment is actually going up. So how do we square that circle? That's one of the things that we're going to try and come back to. So here's the case. A 75-year-old woman with cognitive impairment. She's a retired teacher. Her problems came on suddenly, quote unquote, 4 months ago, when she developed delirium with COVID-19, and her problems have not resolved. She's a well 75-year-old. She's got the high blood pressure, but who doesn't? And dyslipidemia, type 2 diabetes, hypothyroidism. Of course, she's a woman. And she is active during the summer where she golfs. She used to swim each day, but had to stop that with the COVID restrictions. And what the family describes is she's got a bunch of issues, and she's got the form of dementia where things are kind of turned up. She puts things down and can't find them. She goes and looks for them and gets lost in what she's trying to do. And she asks the same question more than once. And she's become, which is a big thing for her, actually not for her because she doesn't have insight, big thing for her family. She's uncharacteristically irritable, which is not her prior way. So we got some basic tests on her. We got the free cog, which if you haven't seen it, give it a go. It's sort of like the MoCA, but without the stealth copyright. 17 out of 30. You can calculate a memory index in it like you can with the MoCA. It's 9 out of 15. It has really good questions about executive function, and she was 4 to 5 on that. Her mini-mental state score was 21 out of 30. On examination, some slowing of gait. She also had paratonia, which I hope is understood by everybody, but if not, please ask about it. Her CT scan was said to have age-appropriate atrophy, a small degree of white matter change consistent with chronic cerebral ischemia. In other words, the CT scan of a 75-year-old with high blood pressure. So what's going on here? Does her age matter in this? So if you think about aging as a general proposition, wherever age is important in a multivariable model, frailty will be important too. So now the question is, well, what do you mean by frailty? So there's a couple of ways to think about it. One, of course, is the frailty phenotype, which is the sometimes called free frailty or sometimes called physical frailty or the frailty syndrome. And it considers 5 factors: weight loss, fatigue, reduced activities, though not IDLs. So they focus on high order function, so that they're not looking at disability. Poor grip strength, slow walking speed. If you only got 1 or 2 of those, you're pre-frail. If you got none of them, you're robust. If you got 3 or more, you're frail. So one of the cool things that's been happening in the last 10 years or thereabouts is the growth of geroscience. And what geroscience aims to do is it aims to link aging to chronic disease. And so there are people who believe they're the pillars of aging. There are also people who say the hallmarks of aging. They still seem to be able to get along. And so the pillars of aging have these many things that are seen, and notably include inflammation that happen in aging as a general proposition and happen in many diseases as well. And they say that's not by coincidence. So geroscience is increasingly a useful thing to know about. The other way to think about frailty is what my late colleague Arnold Mitninsky and I, and a man who in those days was Arnold's father-in-law, Alexander McGillner, published in 2001. And we said that deficit accumulation can be quantified with the frailty index, which allows discrimination of the degree of frailty. So the frailty index score, and I see the WE formula has shifted around just overnight. In any event, it's the number of deficits that an individual has divided by the total number of things that we counted, because we've always worked with existing data sets or put the data sets in place that come from either epidemiological surveys or clinical records or some such. So there's not an inexhaustible number of things that we can consider, but whatever we've got, we count the things that are potential health deficits for an individual, those potential health deficits that actually are. So hypertension, blood pressure, if it's hypertension, it's a health deficit. We count that, then we divide by the number of things that are around to be counted. So just for clarity, say that we have an individual who's got 50 health deficits were considered for that person, for everyone in that group. This particular individual has 10 things wrong or 10 health deficits. Their frailty index score is 10 divided by 50, which is 0.2. Sorry, I've just noticed an errant timer. There we go. So 0.2. So I'm going to show you now why I believe this is really important for us to get to grips with if we're going to understand aging from a population basis. So on the x-axis from actually age 15 on up is age, and on the y-axis is the degree of deficit accumulation or the degree of frailty. And the black line is the mean degree of frailty, and the wobbly bits around it are variability in estimates from 8 successive 2-year waves of the National Population Health Survey of Canada of blessed memory. And so the first thing you'll notice about that is that with age, the degree of frailty increases. And, that's not counterintuitive. The older you are, the more things people have wrong in general. But it's not everybody has the same number of things wrong. So everyone who's 85 years old is 85 years old. But not everyone who's 85 years old has the same number of things wrong. And it's this variability which gives rise to frailty. In fact, the statistical definition of frailty when it came about in 1979 was variability in the risk of death for people the same age. That famously then was translated into variability in the risk of an adverse outcome for people with the same degree of exposure. But however you want to do it, that statistical sense correlates somewhat with this approach to frailty by saying we're interested in the variability in the number of things that people have wrong with them, but in relation to some sense of age peers. So it turns out that as we age, things stereotypically go wrong as we accumulate deficits. And so in this wee cartoon here, you can see that on the left-hand side of the screen is a person, happens to be a male by the look of him, and he is out running. Now, again, this is obviously an older guy, right? Got a bit of a gut on him, and you know, he's got 2 feet down at the same time, not sort of running with a gait that would have him sort of floating along the sidewalk. But he's out for a run. Whereas this person, and these cartoons are both based on 83-year-old people. This happens to be a woman, and she is towards the end of her life. She's spending most of her time in bed. So this change in mobility and the change in function, and commonly, as we'll see, the change in cognition and the change in social engagement, these things happen stereotypically as the degree of frailty increases. And it turns out that we don't have to be very sophisticated to look at some of these integrative items, the ones that I've talked about: mobility, function, divided attention, giving rise to cognition, social engagement. So let's look here. On the x-axis is a frailty index based on a comprehensive geriatric assessment. These are data from the Canadian Institute of Health and Aging. And on the y-axis is the cumulative distribution of people who have those scores. So if you look, say, with the timed up and go test, the folks who have no impairment in their timed up and go, they have a different distribution. It's shifted more to the left. They have, in general, fewer things wrong than the people who have the impairment present. And likewise, that's for the timed up and go. There's another test called the functional reach, which you lean forward and such. So you can test it, but you can also just get a history of falls, and you'll come to much the same conclusion. Or an observation, you look at the person and say, well, they're not walking that well. So it's not really a lot of sophistication and precision you need to detect a clinically important deficit that's going to help then define other things that the person has, because the fundamental feature with old age, the problems of old age, come as a package. So if you see one thing wrong like this, it's likely other things will be wrong too. Now, it might be the case that all you're seeing is someone who's got the bad hip because they've got arthritis on that side, but you'd be able to distinguish that fairly quickly, and you would not then find it unexpected that their frailty index score would be lower than someone who has it without any specific cause for the slowing that they've got. And so what we've done with this thing called the clinical frailty scale is to try and look at those key features: cognition and function and mobility and balance and social engagement, and also health attitude, a number of illnesses that people have, and translate that into the typical profiles that people will go through as they become frailer. So in most clinical series, the best you're going to see is managing well. There will be some people who are very fit, but they're not very common. They're not that common and they're even less common in clinical series as well. So what does managing well means? These are people whose medical problems are well controlled, even if they're occasionally symptomatic. But these folks are often not regularly active beyond routine walking. And this is designed for when you're seeing folks in the emergency department. So we talk about the baseline, not what they're like in emerge, because acute illness has a way to homogenize what a lot of old people look like. It's what they were like 2 weeks before they got sick. And so what keeps them from being fit is the degree of exercise that they have got. So the first hint of frailty is very mild frailty. And this is people who are having the early transition from complete independence. So they're not depending on other people every day for help, but often their symptoms limit activities. And when you talk to them, they'll often complain of being a bit slowed up compared to the way they used to be, or they'll often complain of being tired during the day. And so this is living with very mild frailty. But contrast that with someone living with very severe frailty. They're now completely dependent for personal care, and they approach the end of life. And typically, they could not recover even from a minor illness. So they're spending more time in bed. And often they're spending of that time they spend in bed, it's not awake. So that person is frail, and this person is frail too. And you see this person even freed frail. But the point I'm making is that we can't just say frail, not frail. We as geriatricians in particular can't say frail, not frail. Frail, not frail is often used as a polite form of ageism. It's important that we talk about the degree of frailty and bring about approaches to care that take that into account. So what I've said so far is I've talked about frailty. I've defined it in a couple of ways. I've discussed its relationship with aging, and I've talked a little bit about the ways in which we can recognize frailty from a clinical standpoint. So now we're going to move to the second objective, which is to discuss frailty and the relationship. It is to make the case that we should see late life dementia as a multiply determined disorder in which frailty plays a crucial role. That's objective 2. That's what we're going to go after next. So remember this, we saw that x-axis is age, y-axis is degree of frailty. And now what I've done is I've hand drawn these little crude things here, and this is the doubling times. So those of you who are financially astute, you'll look at an average rate of deficit accumulation of 4.5% per year, and you'll translate that instantly with the rule of 72 into a doubling time of every 15 years, and you'll be right. And the analogy holds exactly. As people are accumulating things wrong with them, what's important is not the first doubling time between age 15 and age 30, it's the last doubling time, which actually turns out to be between age 75 and 90. Now, you might say, well, hang on, look, there's going to be people between the ages of 1905, and there are, but except from clinical series, those folks are so uncommon that they could be a rounding error. But the more important thing is that in Canada, this is when most people die, between the ages of 75 and 90. And not by coincidence, a lot of other things going on during that time as well. So it's not this first doubling time. You're 15 years old, you got almost nothing wrong with you. You double that to 30, it's, twice almost nothing wrong. It's still pretty much almost nothing wrong. It's this time. It's what's happening in this period, age 75 and older. So I work at the Halifax Infirmary. This is from a few months ago. It'd be the same today, except worse. If you know the NAIDOC system, the National Emergency Department overcrowding score, it's here at 227. Generally 100 and over is said to be an important degree of overcrowding. I remember this particular day because it's the first day that we'd gone past 225, and yet we'll have a number today or tomorrow that will look very much like that, and it will get worse again. So we've got overcrowding going on everywhere. How come? So hospitals are hotbeds of fantasies about why this is happening. And they're talking about, well, families come and drop them off, they won't take them back, and blah, blah, blah. And there's people who shouldn't be here, and they're sending them in from nursing homes. And there's an extent to which that's true, but it's only a minor feature about what's going on. But it's what we need to deal with if we're going to talk about frail older adults who become acutely unwell. But if we stand back, we think about this. We'd say, hang on now, look, age 60 to age 100 on the x-axis, the cumulative risk to develop dementia on the y-axis. And look here, when does that really tick up? It ticks up at age 75, when the last doubling time starts. And we could show the same information for new diagnosis of congestive heart failure, that's slightly older. Recurrent, repeat admissions to hospital with chronic obstructive lung disease, acute exacerbation. That's just a little bit younger when we start to see the takeoff in that. The idea, and what goes with the geroscience view, is that what's happening is people are accumulating deficits. And that's happening upstream. But the more things they have wrong with them, the more likely they are to get the things that we recognize, like falls and delirium and fluctuating disability, as being illness presentations in older adults. And the reason this is so critically important, quite apart from why dementia is going to look, or I'll make the claim that dementia looks like this, as something that's happening as a result of a bunch of things happening upstream of it. The reason it's so crucially important is that in 2021, the leading edge of the baby boom began to turn 75 years old. So you want to know what's going on with the NEDOCs and the overcrowding and so on and so on. COVID has been crucially important, but COVID is going to go away, please God. This aging the population is not. And this wave is not going to crest for at least another 10 years, and it's going to be in there for 15 years after that. So those of you who are the young people, thank you for doing geriatrics, because the need for geriatricians is pragmatically infinite if we're going to try and improve care. So is dementia frailty syndrome? So the gist of the argument would be this: if frailty is related to aging, and if aging be multiply determined, then that's setting us up for dementia as a frailty syndrome, if we can demonstrate that deficit accumulation gives rise to frailty. So that's where we turn next. So what I want to do is to say a few things first about why this is not entirely implausible. I'm just going to focus on one thing. Delirium is, as we know, a potent risk factor for dementia. And delirium increasingly looks like inflammation is playing a really important role in that. And we know that inflammation is it plays an extremely important role in aging itself. And we know that what's going on in the periphery with respect to systemic inflammation, what used to be called sterile inflammation, because there wasn't a particular thing, there wasn't an infection going on, but the inflammation is going up. We know that is really important for what happens inside the brain. And we know that microglial activation is an important aspect of what happens with delirium and dementia, and is made much more likely when there's a lot of peripheral inflammation going on as well. And of the many, many lines of evidence that have come out for this is something that came out last year, which looked at common infections and dementia by the time since the infection. So when people developed an infection within 3 months to a year of that, the risk of dementia diagnosis went up, other things being equal, and that risk persisted for a long time. And COVID actually really drew this to attention, and it showed the importance of the degree of frailty in all of this. So here's survival in COVID-19 by the clinical frailty scale, which we've gone over. So these would be the fit folks. They were surviving not too badly. Here's the frailest people, and they're dying off at quite a rate. And this is days since hospitalization. So there's a very big early mortality amongst that. It was hard to see by delirium, but it's quite clear if you do delirium by frailty. So the people who were the fitter folks and who got ill, and the people who were the frailer folks and fitter and got delirium, frailer and got delirium, we see that there's divergence within these two groups. Now, before I go further, let me just pause for a moment and let me underscore that the adverse outcomes that befall older adults is not just a matter of their illness or their frailty. Other things are important too. And my colleague Melissa Andrews has kind of captured a lot of the social things into what she calls a social vulnerability index. And young Jasmine Ma, who is working with us here now on a multi-year training program that includes internal medicine, geriatric medicine, a master's, and now a PhD. She's taken a look at some of the data we have about patients seen at the Halifax Infirmary by a geriatrician who was working on the internal medicine consult service at the time, and she's demonstrated the important role that social vulnerability plays. So that's in orange. So whether or not someone comes into the hospital is mostly, and this is adjusted for a bunch of things, including severity of acute illness. And so frailty is the major driver for whether people get admitted compared to social vulnerability. Whether they stay a long time is much more about social vulnerability than it is about frailty. Whether they get turned into the dreaded alternate level of care, the LC status, the mark of the beast, both play a role. Death, chiefly a function of frailty and the chance of being discharged home. Frailty goes against that a lot, but so does social vulnerability as well. So social vulnerability, a very, very important part. It runs together with frailty, but has an impact separable from that. So now let's get back to trying to build the case about dementia. So we'll start with delirium. We know that delirium is an important risk for dementia, and the effect size, Cohen's D or Hedges G, depending on which side of Cambridge you're brought up, is quite substantial. So a moderately sized effect, 0.47. We now turn to some data from a brilliant young PhD student, now a brilliant postdoc, Lindsay Wallace. In her PhD thesis, she looked at Alzheimer's pathology, the degree of Alzheimer's pathology, a little of it, none to a whole lot of it, by the chance of being diagnosed with dementia. So remember in the olden days where people said, you could only definitively diagnose dementia by looking at the brain under the microscope. It turns out not to be correct. Lots of people don't meet the criteria for dementia, had phenotypically characteristic Alzheimer's. So they don't meet it neuropathologically, but they sure did in life. What do you know about them? They tend to be folks with a high degree of frailty. Whereas on the other end of it, say up here, people with a very substantial degree of pathology, many of whom are still able to resist dementia. What do we know about them? They had a low degree of frailty in all grades, particularly here in the middle where most people lie. Frailty is the difference between not having the pathology, but having the pathology and expressing it as dementia. So higher frailty associated with higher odds of dementia, especially in people with low Alzheimer's pathology. And this fits into a body of work as well. It should, because this is where the data came from, that the Rust studies led by David Bennett at Chicago has drawn to attention that mostly what's happening with late life dementia is that most of it is mixed. And it's not, Alzheimer's vascular, it's a whole bunch of things that play in. In fact, in a report in 2018, only 8% of people from their retirement communities study and their religious orders study, only 8% of people had pure Alzheimer's disease. So everybody else had other things wrong with them as well. And then what Lindsay's work has added in a few studies now is that people who have Alzheimer's disease without dementia tend to be less frail than those in whom dementia is diagnosed. And this now she's cross-validated in a UK database as well. So that's about resisting the pathology. There's a nice bit of work about resisting the biomarkers. I'm going to switch now to some work from the UK Biobank published earlier this year with our group, in which we looked at the impact of the degree of frailty and the expression of genetic risk. So red is the high polygenic risk, blue is the low polygenic risk. When people have a low degree of frailty, there's quite a big impact coming from the red relatively. So quite a big impact from a high genetic risk. When people have a high degree of frailty, there's still an impact from that. Proportionally, it's not as much as it is down here. Relatively, not as much. But you can see that with high frailty, even people with a low polygenic risk are still at a high risk to develop dementia. And interestingly, if you look at the impact that healthy lifestyles have, much of that impact is mediated by the degree of frailty. So here's people who had no healthy lifestyles, they ate and drank, smoked, and did as they pleased. And you can see that for both men and women, their frailty index scores tend to be higher. Whereas the people who did all the right things, their frailty index scores tended to be lower. And this is one of the ways that leads us to the conclusion, one of the lines of the argument leads to the conclusion that frailty is less a disease. It's a thing that profoundly influences disease expression. So it remains the case, as it was back in the days about the brain under the microscope, that people with a healthy brain under the microscope with a healthy body are at the lowest dementia risk. And people with the highest number of plaques and tangles and Lewy bodies and other sorts of things are at a high risk if they're frail, but their risk can be lower if they're fit, even though their burden is high. So that's what I want us to think about in terms of the case for seeing late life dementia as a thing that happens in a lot of people when they've got a lot of things wrong with them. So it's the role that deficit accumulation has in expressing the neuropathology. So if that's true, what does that mean for how we treat patients, do trials, think about prevention, and aim to treat dementia? So what it means for how we provide healthcare for older adults, and I won't spend a lot of time on this. This is a geriatrician audience, because I was talking to other groups, we'd have to spend a lot of time going through this, but I think every geriatrician knows that routine hospital care is unnecessarily risky. It doesn't serve, in fact, it's hostile to the needs of frail older adults, particularly when they're most in need, particularly when they're acutely ill. So we know if we do better on this, we should do better in a bunch of ways, including possibly preventing dementia. So just to be clear, you've probably heard of the new Canadian frailty risk measure from CIHI, and in some of the validation work done with that, people who were defined as frail in that was about a third of hospitalized seniors. They're much more likely to be high users of hospital beds and be readmitted within 30 days and to die within a year and such. And they're subject to a great deal of unnecessary suffering, not just for them, but for everybody. I mean, no one benefits from sleep deprivation. The fact we can get away with it very often, we used to be able to in younger people, is not a reason to keep at it when we have a high portion of people who are at risk from that, or from polypharmacy, or from untreated pain, or for not being mobilized, and so on and so on. And these risks are real, and the reason they're unnecessary, I think, is pointed to us in this. So many of you will recognize the paper from Daniel Hall and colleagues in JAMA surgery, and they just said, what about if we had a screening initiative? Will that, just screening for frailty, what will that do? And it had an amazing impact. 12.2% of people died before, at 30 days before this was brought in, and 3.8% after. And same way for the 1 year mortality, 34% at 1 year versus 11.7% after. Now, it's not a randomized controlled trial, right? So if you got all your things out about, I've got the checklist here, and that was not randomized, and the people weren't blinded, they knew if they were looked after, and it doesn't matter. What this is telling us is that there is a big amount that we can do, apparently with simple things. So it behooves us to understand how unnecessarily risky it is to have hospital care in its present form. And we got to be the folks who would advocate for that. So a couple of years ago, we had the CCCDTD, or whatever it was called. It actually was called the CCCDTD-5, the fifth crack at Canadian Consensus Conference on the Diagnosis and Treatment of Dementia. And we borrowed heavily because now we thought about prevention, but that would have added a P in, and that, would have disrupted this otherwise elegant CCCDTD. So you may recognize this from the Lancet Dementia Commission when they looked at the role across the life course of things that give rise to dementia in late life, and concluded in some fairly sophisticated modeling that the potentially modifiable risk factors, taking into account that some of them go together and so on, it might be possible to prevent up to 40% of dementia by these sorts of things. And in the exercise we went through in Canada, we looked at things that you could do that would help people with all of this. And the thing that everybody comes to in much of the work is exercise. So a number of groups recommend physical activity of at least moderate intensity to improve cognitive outcomes for older adults, and particularly people with mild cognitive impairment who are at a greatly increased risk. And so I won't go over that a whole bunch more, but I wanted, because everybody knows that, but what was surprising with the Dementia Commission when we looked at it first was the impact that hearing was playing. And between our first report in 2018 2018 and the next one in 2020, that was the thing that improved the most, was where the database improved the most was hearing. And there's another one that's the meeting's going to be in 2023. And already we're seeing that there is a lot of work that's been done subsequent to this to look at, do hearing aids make an impact? And in these in systematic review with the longitudinal associations, it appears that they do. And it also appears that you can actually improve cognitive test scores with this, though that effect is a bit smaller, isn't it? We'll come back to that in a second. So my argument for how this should change practice, or what we should be thinking about for clinical trials and dementia prevention and such, is that we have to stop seeing biomarkers, including neuropathology, presumably the ultimate biomarker. We have to stop seeing them as disease defining. We have to see them as risks. And we have to stop turning away the people who are most likely to progress to dementia. Who are those? Frail older adults with delirium. They would never get into a clinical trial. And everybody's very proud about that. We're having proof of concept. Well, what concept are you trying to prove? And what about all this bias we claim to be concerned about if we're excluding most people who are most at risk, spending tens of millions of dollars on trial-ready cohorts? Do you want a trial-ready cohort for someone at risk for dementia? Every hospital every day has people with delirium. You want to do something, work on that group. So we also have to have better targets. So picking out a single protein abnormality and imagining that will be the target for as the general case, that is highly unlikely to be so, and yet here we are, lecanemab. So the other thing is that a great tragedy with cholinesterase inhibitors was that we really advertised them as being memory drugs. That was what people thought it was. But very early on, from the earliest stages with the trials, you could see improvement in people whose memory was about the same, but what was much better than with them was their executive function. And it will be the case for some time that if we can improve executive function, it's better to have a good memory than a bad one. But if you get a bad memory, if your judgment and insight and ability to compensate is good, that's going to be where we could have some effort. And that's going to oblige us to open up to multifactorial interventions, I would reckon. So back to our woman, her age matters because she's at risk for unnecessarily risky care, for no access to multifactorial prevention intervention, for incomplete resolution of her delirium because we don't routinely do the multifactorial prevention interventions might be helpful, of months of a delay in dementia diagnosis, and to great operator dependence into whether she's even offered a treatment trial for her dementia when she shows up, because she may be the day where someone doesn't really believe in treatment. It doesn't make any sense. That's a bogus stance from my standpoint. Many people will do well, and you can't tell by looking at them for the most part. But I digress. So let me sum up then. So what we talk about first, and what does frailty consist? It's a multiply determined state that reflects disordered or accelerated aging. My take on it is there's many ways to be frail, not just the physical frailty. There's a bunch of things that can give rise to a range of clinical manifestations. People have many things wrong. And that however we do it, we need to talk about the degree of frailty. We geriatricians in particular need to talk about the degree of frailty, lest we slide too readily into ageism. Frailty appears to have a crucial role in the clinical expression of dementing disorders. I think there's a body of work growing in respect of that, and I have been really interested to see that the cardiologists are cottoning on to this too for heart disease. And there seems to be a real role for lifestyle factors, including hearing, in mediating the degree of frailty. So going forward, I think that we need to have interventions that treat aspects of aging themselves, right? So the geroscience agenda is putting in place, interventions that can help to treat aging. So I'm talking about the senolytic drugs and senostatic drugs and the senostatic practices. Those things we need to look at very carefully. And this is, I think, where geriatrics has a huge chance to help move forward the agenda, to turn the ship around about being very disparaging of frail older adults, because in them may lie some secrets that can allow everyone to benefit. I personally think that the overwhelming data right now make the pretest probability of a single protein abnormality being good for all of late life dementia dubitable. And I think we have to doubt current exclusion criteria and be motivated to do better with that. And finally, remember we said at the outset that we had this kind of odd paradox, perhaps, where the number of dementia cases was falling per capita and age adjusted, but cognitive impairment was going up. That's because there's no reason to suppose that prevented dementia will be the same as normal cognitive function. So let's not make the mistake of having successful outcomes and not recognizing them as such, because we have in mind some fantasy about what normal cognition for an older person is like. So no one does work like this on their own. I've been really fortunate over the years to have funding from groups like Canadian Institutes of Health Research and such. I want to draw particular attention to the Fountain Family Innovation Fund at the QE2 and to the Dalhousie Medical Research Foundation. These are philanthropic groups that allowed me to have the time to undertake this work while also doing a bunch of doctoring, and as well to have funding that allowed me to withstand the whims and fancy. Oh, I have a meeting coming up. Withstand the whims and fancy of peer review. So to survive for a year or two, or twice to survive for a year without much peer-reviewed funding as we tried to push ideas forward. I also want to acknowledge a great number of colleagues and friends, particularly the late Arnold Mitnitzky, who died in May of 2021. One of the great joys of being an academic and aging in academia is that folks that you met as prospects then work with the students and saw them to become residents and then fellows and are now cherished colleagues. And I've been really fortunate with respect to all of that. So I want to thank all of them for their help and support and inspiration, and thank you for listening. Thank you very much.
Thank you so much, Dr. Rockwood. I think, my mind was just going to all different places, much of which is I want to show this a recording of this talk to many, many decision makers around our region in terms of how we view frailty. And in particular, the things for me, you had a couple of terms that resonated, that hotbed of fantasy around ED overcrowding, looking at the impact of social vulnerability. So sort of viewing some of those ALC factors from a different perspective. I think it's so important to think about things in a different way. We are going to open it up for questions, so people can put their questions in the Q&A. You can, and we'll try and address them. You can put them in the chat as well. Perhaps I'll kick things off by just saying, so how do you, as part of the senior leadership team at Nova Scotia Health, how do you present this information to shape the conversation in your world around things like ALC, both within the Nova Scotia Health group and in the community surrounding you? So how do we take this and how do we explain it to people who don't work in geriatrics and show and demonstrate how important it is to the decisions that are being made about hospital care every day?
Yeah, that's a great question. So I'll tell you, the single most effective thing I've ever done in my entire career was to come up with those little lines about the doubling times. And because many people who have senior leadership positions or executive leadership positions, where the power is, they're coming at it from not a bad understanding of economics and such. They get doubling times. And so when you say 75 to 90 is for most people the last of their doubling times, why is that? Because you have enough things wrong, you'll die. And so what we're seeing at this stage is a group of people who are at a high risk for all the chronic diseases. And the other fantasy to get rid of is, well, if we didn't treat them all, they just die and then we're done with them. But that's not how it happens, right? Death is still fairly uncommon. And what we need is a way to take into account the harm that we do is paid for in extra long stays, right? When we see the increase in length of stay or the misrecognition of delirium, we find a huge opportunity to save those beds through better care. And there are discussions, arguments about how to estimate how good it could be, but no one can deny the unnecessary harm, the unnecessary risk that we have for the people who come in the hospital, and who expresses that risk the most. Those who are at risk to start. So we need to really look at the frail older adults as our opportunities to shine, and so that type of rhetoric, you don't persuade people the first time out, although the doubling times have brought a lot of people around. But you do help to sensitize people to the need to see this as a tractable problem.
Right. And so the costing aspect, and then also I think, how do we break it down to actually changing the care we provide, or thinking about it upstream at the entry point to hospital, that kind of thing. So we have, I'm just going to check the chat here. And just a comment, thank you for such a great talk regarding hearing impairment, improving cognitive scores. It makes sense. In that now they can hear instructions, words to encode. But are you also saying that hearing is, sorry, I'm reading this. Are you also saying that hearing is a related biological mechanism that causes dementia?
Yes, I am. Yes, I am. And there's some excellent reviews about this. If you just, I'm blocking on the actual name of the first author and the journal, but if you go in, something I read about 6 weeks ago, but if you do a search in PubMed for hearing loss dementia, you will come up with a flood of things. So there's some basic observational studies, but there's a couple of really good integrative neuroscience reviews about why and how it's so important to hear things in order to be able to remember them. And when you start to lose that input, that your brain is not happy with that. A lot of our brain function comes from our social engagement and our interaction with people, and a big part of that is hearing. And just like if you withdraw social stimulation from an individual, their cognition will pay a price. So too, if you withdraw the hearing component of it.
Excellent, thank you. I'll open up to any other questions, any comments for Dr. Rockwood.
Here, and I'll do some advertising. If you know that you've got access to someone who's looking for a postdoc who's really good quantitatively. So with all due respect, I don't mean, hey, I got an A in biostats. I mean someone with a degree in computer science or mathematics or physics or such. Then we've got some really cool things that are going on now. We have a project called the Physics of Frailty, and that's been the most reassuring thing, because it's really what it's demonstrated to us is that geriatrics is a complex specialty, and we get insights from people who are really skilled in the analysis of complexity in and of itself. And so a big part of my job in that is to translate what they're telling me back into words that we can use to look for things from a clinical standpoint. And so I would just, it's a really exciting adventure. So for someone who's mathematically astute, I think this would be very worthwhile, whether they're medically trained or not.
All right, good pitch. Got another question. How does inflammation come into play in terms of prevention and treatment of delirium? Should inflammatory markers be monitored as part of a delirium workup?
Yeah, so I think that's a really good question. There is some emerging work right now in terms of what markers we can use to help characterize this. It's not entirely ready for prime time, but I know that one of the things that our group is looking at is maybe to get a post-delirium clinic and pick folks out of that. And so we're going through exhaustively, well, we're going through with some care now what biomarkers we should look for in that context. And it's fairly impressive, the range of things that might be done to look for standard markers like glial activation, that winds up being fairly tricky when the person is alive. But there's a lot of gene expression work that looks like it can be helpful. And the whole omics revolution, I think, will give us a parsimonious number of things to do. It won't be just one thing. There'll be a bunch of them, and we're not settled yet onto what that bunch should consist. And it's not my area well enough to say more than that, but that's the general shape of things.
Great.
And by the way, if you had to do just one thing, it looks like it's the lymphocyte count. And then if you had to do the second thing, it'd be lymphocyte count and CRP. But they're very, very insensitive measures.
Okay. Good. One other thing, and it came up at one of our discussions this morning, because there's a lot of talk about, again, people involved in or using the clinical frailty scale for screening. Screening in emergency departments, screening in at your family doctor's office, screening as part of your admission to hospital. And do you see that as value add? Are there risks of people applying it inappropriately? Just wondering your thoughts on use of the clinical frailty scale in non-geriatric trained people. How can we use that perhaps as a tool?
So it's tricky. I mean, we came with the clinical frailty scale in the first instance to summarize the results of the comprehensive geriatric assessment. So back in the days of Canadian Study of Health and Aging, we self-consciously mimicked the physical exam bit and the history taking in ways that would allow us to do a comprehensive geriatric assessment. So people had all the items because geriatricians were doing it, but so were neurologists, psychiatrists, family docs, general internists, and it was how they're going to integrate it. And so that's how the CFS was arrived at in the first instance. So it was meant to be what you did after a geriatric assessment. The way it's used in the UK a lot is it's used to screen for who should get a geriatric assessment because they can get them. They've actually invested in those folks. So we've spent a fair amount of time working on this in the Frailty and Elder Care Network. We're actually going to be introducing the CFS as a screening tool, but we've built in a number of safeguards to help, because screening tools should be pretty straightforward, quick, and quite sensitive. And so if you take that idea and then it says, okay, if that's positive, here's some other things that you need to do, and now come back and revisit the CFS afterwards. So the first one is not carved in stone, but it will help to give direction. And the only good thing I can say about it is it beats age, which is the default that often people will go to. And it really is an educational opportunity for us. So now that in this position, I've actually got money to invest in training videos and such like. So, and we'll put all of this up freely available on the Nova Scotia Health website. So it's in the works just now. I'm hoping within a few months we'll have a way to do it that should work, and of course we will validate that and test it.
Yeah, that's wonderful, because that's sort of what our discussion was today. So I've screened them. And now what do we do with them? Or if we're getting or receiving those referrals as a result of someone doing those screening, what are the next steps? So that's good to hear that's training coming.
Yeah. So and that provokes one other point. The point of a geriatric assessment is not to do the assessment. The point is to come up with an individualized care plan, right? Mm-hmm. And that should be obvious, but anyone who's been doing geriatrics for any amount of time or seen more than one team at play, you'll know that there are people who figure they've got their assessment done, then they're done, right? And they put hours and hours and hours into the assessment and almost no time into the execution of the plan. And the other thing is that it's that first 72 hours. That's the important time, right? Those first 3 days, that's our golden opportunity to do something, right? And in a different context, I've been talking to people about the need for geriatricians to be in at the pointy end of care, to be in seeing people when they're at their sickest. Because if you don't break the jar, you don't have to spend a lot of time rehabbing afterwards. Like, we need people who can do that. But geriatrics is a big tent, and it should include some people who are in at the pointy end of care when people are very ill, coming with better ways to care for them in the first period of time. So the other thing that the network is going to do is look at things like early mobilization. And yes, I know about the New England Journal paper, and delirium recognition. And we're hoping, and we will evaluate all of this, and we'll put all our tools freely available, but we're hoping to have pragmatic ways to deal with people when they're at their most vulnerable.
That's wonderful. Wonderful. It's music to my ears. So with that, I don't see any more questions or comments. I think there's a lot for people to process, but you've given us so much important information that we can use to support the work that we're doing. So thank you so much. For the RGP, please check out our website for upcoming event information, for registration, for our educational forums, for our rounds. And again, thank you, Dr. Rockwood, for this incredible presentation today. Thank you everyone for taking the time in your day to join us. And we hope to see you at our next rounds, which will be January 26th. Thank you so much.
Thank you very much.